Chapter 23, Respiratory Physiology, Screencast 3. Please note that in the previous screencast, when I was talking through the title, I misidentified it as Screencast 3. It is Screencast 2 as noted on the information that was covered. This is Screencast 3, and the focus is going to be on resistance, airflow, pressure gradients, and such. So much of what we are talking about now is what we talked about previously with cardiovascular physiology. Remember how I addressed fluid in a tube. So when we look at air is fluid in nature, so it will respond the same way. It will move down a pressure gradient and it will be impacted by resistance. So when we talk about airflow, we really are talking about the amount of air that is moving in and out of the lungs with each breath. There are two things that this is going to be dependent upon. The pressure gradient established between atmospheric pressure and intrapulmonary pressure, that is the driving force. Resistance is going to be a little different than what we talked about previously in the cardiovascular system, because we're going to find potential resistance coming from different areas. It may come from the airways, it may come from the lungs themselves, and also the chest wall. Now, this is a formula that we talked about previously when we introduced cardiac output. And remember, when we talk about flow, it's volume per unit of time. When we talked about cardiac output, it was either mils or liters per minute. And we will see the same thing here when we talk about airflow. And keep in mind, the delta P, that is the difference in pressure between the atmosphere and intrapulmonary pressure, and R is resistance as always. Now, the relationship here is especially important. Remember, flow is directly related to pressure gradient and inversely related to resistance. If pressure gradient increases, we will see a corresponding increase in airflow to the lungs. If resistance increases, we will see a decrease in airflow, and please take note of that inverse relationship between resistance and airflow. Now, as noted previously, when we talk about the pressure gradient, is going to be the difference between atmospheric pressure and intrapulmonary pressure. This is going to be altered by changing the volume of the thoracic cavity. Small volume changes of quiet respiration allow tidal volume, or 500 mils of air, to enter. If accessory muscles of inspiration are used, this volume will increase, and we can see a significantly greater increase in volume during exercise. The increase in airflow is due to the greater pressure gradient. Resistance is definitely something that's a little bit different in the respiratory system. And there are more factors that will result in resistance than what we addressed in vessels. Factors that are going to increase difficulty moving air or increase resistance are going to be change in the elasticity of the chest wall and lungs. It could be a change in bronchial diameter, size of air passageway, or it could be due to the collapse of alveoli. So we will spend some time talking about all of these different sources of resistance. The first that we're going to talk about is decreases in chest wall elasticity. And keep in mind here, if I decrease elasticity, we will increase resistance. We are actually losing elastic recoil, and that is going to be important. Now, as we get older, chest wall elasticity decreases with aging and disease. There could be some other factors that actually also contribute to this. An example could be a vertebral malformation such as scoliosis. This may have an impact by decreasing elasticity. As we get older, there could be arthritis within the thoracic cage itself, or we might see replacement of elastic tissue with scar tissue, and this is something that occurs with pulmonary fibrosis. Now, what is more familiar will be when we talk about bronchial diameter. And this was similar to what happened when we vasoconstricted or vasodilated. Now we'll be looking at bronchoconstriction or bronchodilation. So keep in mind, bronchial diameter will vary inversely with resistance. Bronchoconstriction or occlusion will increase resistance. So this could be caused by parasympathetic activity. It could be histamine. It could be cold, but there also could be an occlusion, and that occlusion could be created by excess mucus or inflammation. Bronchodilation decreases resistance. Factors that are going to result in bronchodilation are sympathetic activity or epinephrine. Now, when we look at the alveoli, it's collapsed alveoli. And this is something that we talked about previously in the anatomy screencast when we talked about the type 2 alveolar cells that produce surfactant. And so without surfactant, there is going to be a high surface tension within the alveoli that cannot be overcome. So now individuals have to work harder to separate the water molecules from each other to allow for inflation of the lungs. This is an especially important factor for infants that are born prematurely. Okay? And what may happen is collapse of the alveoli with expiration, which would result in an increase of resistance. This is a condition known as respiratory distress syndrome. Now, compliance, I want to approach a little differently. Compliance, think about how easily it is to inflate the lungs. So the cost will be cheaper. That's going to be really important. And when we look at factors that are actually determining compliance, one factor is going to be surface tension. Another factor is going to be the elasticity of the chest and lung. Now, elasticity can be a confusing variable because I can have too much elasticity or not enough elasticity. So either of those are going to make things difficult. So it is important to keep in mind that we want that sweet spot or just the right amount of elasticity. If there's too much elastic tissue, then you have to work harder to overcome the elastic fibers. Imagine you're in a physical therapy program and you're working with the resistance bands. And as the bands become thicker, there's more elastic tissue, and it becomes more difficult to separate them or pull them as part of the therapy program. So overall, we want to make sure that it is easier for the lungs to expand, and compliance is desirable. Also remember the other factor that contributes to compliance is high surface tension. So if surface tension is high, you have to work harder to inflate the lungs. So that, once again, is why surfactant coming from the type 2 alveolar cells is especially important. Now, if we look at a number of conditions that are increasing resistance, we've addressed some of these along the way, but let's focus on some of them in a little bit more detail. One could be asthma. Asthma is a decrease in the size of the lumen of the bronchiole. We can see a decrease in compliance that could be due to pulmonary fibrosis. Overall, there's going to be a need for more forceful inspirations, and you really are increasing the cost of breathing. And if we look at more forceful inspirations of respiratory disorders, they really require a significantly high amount of energy. If we look at individuals that have obstructive disease or pulmonary disease in general, it can actually result in a 4 to 6-fold increase in energy requirement. So think about this. In these individuals that have significant respiratory disease, basically anywhere from 5 to 25% of their total energy expenditure just goes to breathe. So if you know someone that has these pulmonary conditions, you probably have noticed that they get exhausted really easily. But think about this. Up to 25% of all the energy they expend on a daily basis just goes to breathing and not anything else. Now here, this is an overview of factors that actually contribute to airflow. First, we look at the flow formula. So we have the pressure gradient divided by resistance, which determines flow. And we can see the pressure gradient is the largest factor. So differences in the pressure gradient are going to be created by the contraction of skeletal muscle, creating greater changes in volume of the thoracic cavity. If we look at bronchial diameter, this is reflective of vasoconstriction, vasodilation, except here we're talking about bronchoconstriction and bronchodilation and the impact of the radius or diameter of the lumen of the bronchiole. And remember, this is an inverse relationship. Bronchoconstriction results in an increase in resistance. Bronchodilation is a decrease in resistance. And then we have factors of compliance. So the ease with which the chest wall and lungs expand, and also surface tension within the alveoli. So those are factors that are contributing to resistance. Now, the last couple of slides are going to be talking about ventilation, and then we'll be looking at or spirometry, how we measure respiratory volumes. Minute ventilation, this is going to be comparable to cardiac output. This is the process of moving air into and out of the lungs, and it is the amount of air moved between atmosphere and the alveoli in 1 minute. Tidal volume is the amount of air per breath, and generally it's about a half liter or 500 mils. Respiratory rate is number of breaths per minute. So go back to cardiac output. Cardiac output was determined by stroke volume and heart rate. Here we're looking at tidal volume and respiratory rate to determine minute ventilation. So if we look at a simple or sample minute ventilation, we can look at 500 mils as a normal tidal volume. 12 breaths per minute is a normal respiratory rate, and that would work minute ventilation to be about 6 liters per minute, and that's an average value. Now, what we have to take into account now is anatomical dead space. This is the space of the conducting zone. Remember, this is an area in which there's no exchange of respiratory gases. This accounts for about 150 mils. So if we want to calculate alveolar ventilation, which is the amount of air reaching the alveoli per minute, you have to take dead space into account. So here, this is how we would calculate that. We would take tidal volume, but we would have to subtract from tidal volume the conducting zone, or that anatomical dead space. Then we would multiply it by the respiratory rate, and that would actually give us alveolar ventilation. So here, we have a tidal volume of 500 mils. We're going to have a dead space of 150. So that gives us about 350 mils, and we're going to multiply that by 12 as respiratory rate, and that gives us 4.2 liters per minute. Notice alveolar ventilation will always be lower than minute ventilation because we're only talking about air participating in gas exchange. Now, one breathing pattern that may maximize alveolar ventilation is going to be deep breathing patterns. Now, we also have to address the concept of physiologic dead space. Normal atomical dead space plus any loss of alveoli. So in a healthy person, we're not really going to worry about physiological dead space. Now, there are some disorders which actually decrease the number of alveoli that are participating in gas exchange. This could be due to damaged alveoli or changes in the respiratory membrane. And a good common example of this would actually be someone with pneumonia. But keep in mind, in a healthy person, anatomical dead space is equal to physiological dead space because there really is no loss of alveoli in a healthy individual. Now, the next slides are focused on what we did in lab for respiratory physiology, and that is the measuring of respiratory function or pulmonary function testing. It requires a spirometer. And basically, this is a process in which you assess respiratory health. And there are standard values, for everyone pretty much. Now, there will be a total of 4 volumes that can actually be measured. The first is tidal volume. That is the amount of air inhaled or exhaled per breath during quiet breathing. Notice it's inhaled or exhaled. It's not both. We have the inspiratory reserve volume. This is the amount of air that can be forcibly inhaled beyond tidal volume. This is a measure of compliance. And then we have expiratory reserve volume. That is the amount that can be forcibly exhaled beyond tidal volume. And that is going to be an index of elasticity. There is also residual volume, and this is regardless of how forcefully you exhale, there always will be some amount of air left in the lungs after even the most forceful of expirations. Now, the following are capacities, and they are calculated using volumes. Inspiratory capacity will be tidal volume plus inspiratory reserve volume. Functional residual capacity is expiratory reserve volume plus residual volume, volume left in lungs after a quiet expiration. Vital capacity. This is tidal volume plus inspiratory and expiratory reserve volumes. This is a total amount of air a person can exchange through forced breathing. To measure this requires a maximal inhalation with a maximal exhalation. Total lung capacity is really just the sum of all volumes, including residual volume. So this is the greatest amount of air that the lungs can actually hold. Now, there are some other measurements that are actually describing the rate of air movement. Primarily, this is forced expiratory volume. It is the percent of vital capacity that can be expelled in a set period of time. Typically, we will see FEV1. That is the percentage expelled of vital capacity expelled in 1 second. Generally, we expect FEV1 to be in the ballpark of 75 to 85% of vital capacity in a healthy person. This will be less in patients that have emphysema or asthma or overall poor expiration. FEV1 helps us distinguish between obstructive versus restrictive disease. Obstructive diseases such as emphysema are those diseases where it is primarily difficult to expire, whereas restrictive disease such as fibrosis is where it becomes difficult to inspire. Now, there are some other measurements, and one is known as MVV, or maximum voluntary ventilation, and this is the greatest amount of air that can be taken in and then expelled from the lungs in a minute. This requires an individual to breathe as quickly and as deeply as possible, and generally it's about 15 seconds. This is not something that someone could do easily for an entire minute. And this can be as high as 30 liters per minute. And keep in mind when we compare this to 60 liters per minute at rest, MVV will impact all respiratory disorders. Now, this last image here is that of respiratory volumes and capacities at normal volumes. So here we can actually see tidal volume, okay? And so here is inspiratory reserve, and notice it's going to be between a tidal inhalation and maximal inhalation, okay? Here is vital capacity, okay? Vital capacity, once again, is going to be measured using a forced inhalation and forced exhalation. And keep in mind, vital capacity is typically the most commonly used parameter when we're talking about pulmonary measures or pulmonary function testing.